In this lecture, we're going to take a look at some various musculoskeletal injuries. The musculoskeletal injuries that we're going to cover here are going to be several different examples other than fractures. We're going to cover the fractures in a separate lecture by itself. One type of injury we want to take a look at is the soft tissue injury, most commonly known as a sprain or even a strain. We're going to look a little closer here at the sprain and grade those a 1, a 2, or a 3. So we'll talk about that more in detail. But first, to tell you, what is the difference between a sprain and a strain? Well, a sprain is when there are stretching or tearing of ligaments, which is what we're going to cover here with this slide. A strain, on the other hand, is when there is stretching or tearing of a muscle or tendon. Strains most often occur in the lower back or in the hamstring muscles in the back of the thigh. Sprains, the P that we have here on the slide, is something that we usually see more often with something such as a wrist or ankle. So we grade them a grade 1, 2, or 3 depending on the severity of the injury. So as you take a look at this slide that I developed, I broke it apart according to what the specific differences were with each of 4 criteria. First, what's the difference in the physical examination between a grade 1 and all the way up to a grade 3? Well, if we look at the grade 1 example, we find that there's minimal swelling or tenderness. So certainly you understand that a grade 1 sprain is the most mild degree of a sprain versus the grade 3 sprain is going to be the most significant or the most extensive degree of injury in regards to a sprain injury. Here there's going to be significant swelling and the ankle or the joint that was sprained is going to be unstable. As far as impairment, again, we have with a grade 1 minimal impairment, certainly a grade 2 is moderate impairment, and that grade 3 sprain, then the impairment is going to be severe. I'm not going to go through and read the pathophysiology section to you, but you see what you can see again as you read all the way across that there are going to be some notable differences all the way from microscopic tearing with the grade 1 up through the grade 3 is where we have a complete tear or a rupture of that ligament. The treatment is important because it does depend on understanding first the severity of the sprain to know what we're going to do about it. We're not really going to do much for a grade 1 sprain. We're going to want to advise the patient to weight bear as tolerated, get back to using that extremity and that joint, go ahead with full range of motion, stretch it, exercise it as tolerated. You're not going to have a splint, you're not going to have a cast, just get to using it again. It'll heal up fine on its own. A grade 2 sprain may have some physical therapy, and it's possible that we might immobilize that with an air splint for a short period of time. But that grade 3 sprain, again, the most severe of the 3, that one is definitely going to have some immobilization for a period of time. That patient is definitely going to need some physical therapy, and it's even possible that they're going to need some surgery to repair that torn ligament. Okay, so we do want to take some time just to cover, hey, what do we do if a patient, especially with those grade 1 or grade 2 sprains come about? What is some general injury treatment guidelines for soft tissue injuries, especially until we get more information regarding the extent of the injury, which can take some testing and some time. So the first thing we want to advise patients to do is stop your activity. You don't want to continue doing whatever you were doing when the injury occurred. It's only going to make it worse. That can cause a grade 1 to extend to a grade 2 or even a grade 3. So stop your activity. That's your first step. Immobilize it to prevent further injury. Now, I know that I talked about with that grade 1 sprain, we wouldn't do any long-term immobilization, but again, we're talking about some pretty much first aid injury treatment here. We're not really sure at this point what kind of an injury we have. So one of the first things we want to do is after we stop using it, we want to stop moving it. So that would also be another added bonus to prevent that further injury. And then what you're going to need to remember is the 4 general elements of any soft tissue injury treatment is going to be RICE: rest, ice, compression, and elevation. When it comes to their ice application, you would want to recommend that patients use ice for about 20 minutes out of every hour, and that they really only need to use ice for the first 24 to 48 hours. After that first 24 to 48 hours, actually heat, warm, moist heat is a little better for your soft tissue injuries, but that ice is going to be necessary for that initial time period following the injury. Then we have compression. Compression is going to be best done with something such as an ACE wrap. You see that in a couple of the pictures there. And then we're going to want to elevate it. Elevate it above the level of the heart is going to be best for improving circulation and improving the healing time with that injury. So rest, ice, compression, and elevation, those are going to be your 4 primary components of injury treatment, in addition to stopping the activity and immobilizing the extremity. Some other things certainly that we would include in injury treatment is going to be the use of NSAIDs, non-steroidal anti-inflammatory drugs, will also be useful in improving the healing of that affected area. Some things too that we can teach patients, not only in regards to the treatment of an injury that has occurred, but it's also good to teach them how to prevent injuries from occurring. So some of the best things we can do as far as patient teaching and injury prevention is going to be to advise them when they are going to be active that they need to start with a warm-up, something such as a 5 to 10 minute walk. They should also stretch, preparing their muscles for a workout or any kind of like sporting activity that they're getting ready to do. That's always important as well. And then conditioning. Conditioning looks at, we're not just going to go out and run a marathon the first day that we decide we want to run. We're going to have to condition for that. So what that means is that we're going to slowly increase activity until we reach a desired point. So those are 3 pieces of patient teaching that is important to share with your patients to prevent future injuries and not just avoid the injury that just occurred. Next, we're going to look at a couple of specific soft tissue injuries that can be fairly common. The first one is going to be a rotator cuff injury. The rotator cuff is a group of muscles that are located within the shoulder joint. It's a group of 4 different muscles, and each of those specific muscles, when it's injured, has its own set of signs and symptoms. So you have quite a long list here of symptoms that a person may experience with a rotator cuff injury. Just know that they're not necessarily going to experience all of them. It's going to depend on the particular muscle and the area in which that muscle was injured. It's also going to depend on the severity of the injury of that muscle. One of the most common symptoms that patients with rotator cuff injuries seem to consistently report is a dull aching sensation in their shoulder, which is fairly constant and worsens when they try to sleep on the involved side. Again, that's one of the most consistent symptoms that patients will report. There's a variety of different types of muscle testings that physicians can do to determine the exact nature of the rotator cuff injury, and in addition to that, they can usually do some x-rays, possibly ultrasounds or MRIs to verify, again, the exact location and extent of the injury. Some things that they can do as far as treating a rotator cuff consist of our conservative treatments, which are going to be those treatments which we just mentioned in the previous slide. So rest, ice are going to be 2 of those components that we can do. We can't really obviously do compression and elevation with the rotator cuff, but we can definitely rest it and ice that area. Physical therapy is also sometimes warranted with this particular injury, and sometimes that's all that's needed to get this to heal. Now, it's important to note that even in minor rotator cuff injuries, they can take on average, about 6 months of rehab in order to get it back to a full range of motion and full function without any pain. If rotator cuff injuries are more severe, those can sometimes usually warrant surgery to repair the torn muscles or the torn tendons. And they've got a couple of different options there. They can do the arthroscopic tendon repair, again, using that arthroscopic surgery like we mentioned in the diagnostic testing lecture. They can do an open tendon repair where they're going to actually make an incision to reattach the damaged tendon back to the bone. It's going to have about the same healing time as an arthroscopic surgery, but the patient may experience a little more pain and discomfort with an open surgery as compared to an arthroscopic surgery. A tendon transfer can be done in really severe injuries where the tendon is too damaged to be reattached and they have to use a nearby tendon as a replacement. And last but not least, in the most severe cases, they could possibly even consider a shoulder replacement surgery for the most massive degrees of rotator cuff injuries. We're going to move to looking at a couple of specific types of knee injuries that can be fairly common. These are known as a meniscus injury and a cruciate ligament injury. We see these types of injuries most often in athletes. The meniscus injury tends to be an injury that occurs if the patient is doing something with their foot firmly planted, but they complete a sudden twist or turn of the knee while that foot is firmly planted on the ground. That usually is the activity that's going to lead to the meniscus tear. With the cruciate ligament injury, we most commonly see that occur when the patient was doing something where they were actually moving and came to a sudden stop, or they made a quick change in direction, or they jumped up and landed wrong on their knee. That's where the cruciate ligament injury tends to happen more often. We've got a couple of signs and symptoms here that we can see. Certainly pain is going to be present with both of these types of injuries. And so it's going to be important for practitioners to be able to distinguish exactly what type of injury has occurred. So with the meniscus injury, something to make note of here is that we're going to do what's called the McMurray's test. And with the cruciate ligament injury, we're going to be doing the Lachman's test. Now, obviously, if somebody presents to a health provider complaining of knee pain, that health provider is likely going to do both of these tests, both the McMurray's and the Lachman's test on the patient to determine what type of knee injury they believe that they have acquired. And what we're going to see is if it's a meniscus injury, the McMurray's test would be what they would have a positive finding in. And if it's a cruciate ligament injury, they would see a positive Lachman's test. So first with the McMurray test, it's a two-step process. They're going to lay the patient back on the table. They're going to hold the knee. The doctor will hold the knee in one hand and the sole of the patient's foot in the other hand. They'll bend the knee fully, and first they'll rotate it inward into a knock-kneed position. And then what they will do is actually rotate the foot internally while they extend the knee out. And they're going to be listening for any clicks or listening for the patient to report any pain as they, again, extend that knee while they're doing an internal rotation of the foot. And then the second process, they're going to go back. They're going to fully bend that knee again, only instead of turning the knee inwards, they're going to turn the knee outward in like a bow-legged position. But again, they're going to then rotate that foot now externally as they extend the knee, again, looking for pain or clicks to support that positive finding with the McMurray's test. With the Lachman's test, they're going to have the patient, again, lying flat and relaxed on the bed. And this time, instead of a full bend of the knee, they're just going to bend the knee slightly, about 15 to 20 degrees. The examiner is then going to hold on to the patient's thigh, and then they're going to put their other hand on the shin, and they're going to actually pull the shin forward with the thigh stabilized and not moving. They'll pull on the shin. And so what they would see here is that knees with a damaged ACL will actually demonstrate more movement during the Lachman's test. And that would be a positive finding there, that they would actually have more of a more freely moving knee joint with that Lachman's test. Lachman's test also does come with some grading. A grade 1 Lachman's test would be mild movement of the leg all the way up to a grade 3, which is going to be severe. The most common treatment for both of these injuries is going to go back to our RICE treatment. Our rest, ice, and compression and elevation is going to be The standard protocol treatment here, it does depend though on the severity of the injury. Certainly more severe meniscus tears or ACL tears are sometimes going to actually require surgery for proper correction. Okay, our next injury that we're going to look at is carpal tunnel syndrome. This is something that we see most often in patients who have frequent use of the wrist area. So this can be individuals who have worked on computers for years. Cosmetologist is another group of individuals that over time tend to develop carpal tunnel syndrome as well. This particular injury occurs in the wrist area, and what happens here is there is a tunnel where the median nerve travels through the wrist and extends into the hand. Over time, this tunnel becomes narrowed because the flexor tendons swell and they actually put pressure on that median nerve. And that's what causes the symptoms that are most often present with carpal tunnel, which is going to be pain, numbness, and tingling in the hand and the arm. Sometimes weakness in the hand will be reported or impairment of sensation. Two tests that can be done to support the diagnosis of carpal tunnel is 1, Tinel sign, and 2, the Phelan test. The first one with the Tinel sign, how that one works is that the doctor will actually lightly tap over the area of the affected nerve. And if that nerve is compressed or damaged, the patient would report a tingling sensation that would radiate outward, known as paresthesia, into the hand. The other test that can be done is the Phelan's test. And this test involves having the patient rest a flexed elbow on a table and then allowing the wrist to fall freely into a flexed position, so to bend, just to allow it to go into a free bend. The practitioner will ask the patient to hold that position for about a minute, and usually in patients with carpal tunnel syndrome, they are very likely within that minute's time going to experience tingling and numbness in their fingers. So easy remembering there is the Tinel sign is going to be the tapping, and the Phelan's test is going to be where we have the patient, again, rest their elbow on the table and let their wrist fall. So Phelan's is falling. As far as treatment for carpal tunnel, we do have some non-surgical options that we can do. Non-surgical options with carpal tunnel syndrome, though, simply prolong the inevitable, because the only true fix for carpal tunnel syndrome is going to be surgical management of the condition. However, for a variety of reasons, some patients may put off surgery for a period of time, and so our non-surgical options are going to be first, wrist splinting. They can give the patient a splint that holds the wrist still while they sleep. That can definitely help with nighttime symptoms, because that is something that patients do tend to complain of, is waking in the night with that sensation of tingling and numbness. Certainly if someone is pregnant, surgery is not really something that we want to put them through during that time. Nighttime splinting would be a good option for them just until they get to the point where they're able to have surgery. But again, I just go back and state that all of these non-surgical options are only prolonging that inevitable or just buying time for the patient for whatever reason. Non-steroidal anti-inflammatory drugs are also something that would be recommended. So some ibuprofen would help. That can help in the short term relieve the pain associated with carpal tunnel. It's not going to do anything, though, to actually improve the condition itself. It's just going to be for pain management. Corticosteroids is another option that may temporarily be tried. They can inject a corticosteroid into the carpal tunnel area just to relieve the pain. It can also decrease some of the inflammation and swelling, which is certainly going to relieve that pressure on the median nerve. But it's also only going to be a short-lived treatment. It would need to be repeated if too much time passed before the patient had surgery. As far as surgery goes, the ultimate goal with carpal tunnel surgery is going to be to relieve the pressure by cutting that ligament that is pressing on the median nerve. There's a couple of different techniques that they can use. As we mentioned earlier with the rotator cuff, when we were talking about the surgeries there, you can go with an endoscopic approach, which is certainly going to minimize the pain and minimize the recovery time. or sometimes it may be necessary to go with the open surgery approach. So with the endoscopic approach, they're going to obviously use an endoscope to place inside the hand. They're going to cut the ligament through that endoscopic procedure, and they're going to, have a pretty quick recovery following that. With the open surgery, they're actually going to make an incision into the patient's palm, just over the carpal tunnel area, and then use that to cut through that ligament and free that nerve. So the last musculoskeletal injury that we're going to look at in this lecture is going to be amputation, where there is a removal of all or part of an appendage. We have a couple of reasons that we can see an amputation occur. The first could be due to a trauma. Traumatic amputations occur most often related to accidents, such as those involving automobiles or motorcycles. We can see traumatic amputations occur with farm machinery or power tools, even firearms and explosives, and frostbite. Disease-related amputations oftentimes occur to diseases such as diabetes, peripheral vascular disease, arteriosclerosis. Chronic osteomyelitis is another reason why we might see an amputation necessary. We'll talk about osteomyelitis later on in a different lecture. A few other disease processes could possibly be the presence of avascular necrosis, and even cancerous tumors may warrant the need for an amputation of an extremity. The last possibility there on our list is a congenital amputation. This is actually when a deformed limb or an incompletely formed limb is present at birth. Usually with these types of amputations, the child will be fitted with a prosthesis that will have to change throughout their life as they grow and develop down the road. We look at a couple of diagnostic tests, particularly some vascular studies. These are mainly going to be done to support both the presence of circulation to a certain extent of the extremity and then the lack of circulation, usually to the part of the extremity that's no longer present or going to be removed. The first is the arteriography. This is going to be done to look for specific arterial occlusions that may be present that are contributing to that lack of circulation and the need for that amputation. The Doppler ultrasound is also frequently used both before and after amputation surgeries. With the Doppler ultrasound, we can use that to assess the presence of a pulse when one is unpalpable, and it can also be used to assess the patency of the remaining vessels in the extremity to make sure that there is adequate circulation to the remaining part of the extremity. In regards to the care of an amputation, particularly speaking to the post-op care, compression bandaging is going to be necessary in the post-op days following the amputation to make sure that the stump is properly formed and that bleeding is controlled. Assistive devices may be necessary, especially for lower extremity amputations. And a prosthesis is something that the patient's going to be looking at down the road. The amputation is going to, the prosthesis application is going to depend on, one, the area that was amputated, and two, how much healing needs to be completed before the prosthesis can be fitted. There are some prostheses that actually can be fitted immediately right in the operating room as soon as the procedure is over, but some are delayed until that limb or the residual limb has been given time to heal. Lower extremity amputations require a much longer period of time for healing before the prosthesis can be fitted. On average, they need to be full weight bearing on a permanent prosthesis about 3 months after the amputation of a lower extremity. Replantation is another component that we need to talk about when in regards to amputation. Replantation is when they actually resuture the amputated limb back into its correct anatomic position. This is best done with a finger amputation. It's going to use microsurgical techniques, so they're going to actually be reconnecting blood vessels and nerves under a microscopic setting in the OR. And so there are some really important post-op nursing considerations for a patient who has undergone replantation surgery. The post-op considerations mostly center around ensuring adequate circulation at all times to that replanted extremity, and so that we have the best possible outcome for success in successful replantation of that extremity. So these nursing interventions would include things like keeping that limb elevated, keeping the room at a warm temperature. Usually they recommend keeping the room around 80 degrees. This will help to prevent compensatory vasoconstriction of any of those peripheral tissues. We're also going to put a strict ban on cigarette smoking with this patient, and they actually can't have any nicotine or even caffeine products for at least 7 to 10 days following the replantation surgery. One final intervention that we're also going to put in place with the replantation would be the clothing that the patient wears. So again, we don't want any type of constriction with any part of the circulation, so we're going to want them to wear loose clothing and avoid any kind of restrictive or tight gowns or pajamas. One of the last things we need to look at here with the amputation, or one of the last two things we're going to talk about here, is complications. The most common complication known to occur with an amputation is going to be a hemorrhage. Hemorrhage is most likely to occur immediately following the amputation, whether it's traumatic and occurred suddenly, or whether it was done in the surgical setting, say due to a disease process. We're always going to be concerned about hemorrhage in the immediate period following the removal of the extremity. So we're going to watch closely for that. Some other problems that we can potentially have would be a wound dehiscence, where the wound reopens. Most often this is going to happen due to some type of strain on the incision. Gangrene and infection are also some other problems that we can see. Infection is going to come from possibly contamination during a traumatic amputation, as it happens suddenly without proper care or preparation. Infection can also come from contamination during the surgery or even during the recovery period if there was improper dressing change techniques being followed. Gangrene, on the other hand, is when there is decay and death of the tissue that results from an interruption in the blood flow to that area. And again, this takes us back to why I was mentioning it's really important that we verify, or that physicians verify before going in for an amputation, that the part of the extremity that they're leaving has adequate circulation. And then it's equally important for the nursing staff to ensure that circulation is optimized and maintained in that post-op period. So if not, this is one of the things that we can see develop as a problem. Edema sometimes is expected, but we do want to watch for it. It can complicate things for us, especially if there's a significant amount of swelling around the incision or in the extremity. Contractures is something that we would see, maybe not in the immediate post-op period, but in the weeks and months following the amputation. If the patient doesn't use the remaining joints in that extremity, they are at risk due to the limited mobility of acquiring contractures. The last complication, which is a fairly common complication that we see with amputations, and we even expect it, especially early on in the amputation process, is phantom limb pain or phantom sensations. This is pain that is very real to the patient, and it's felt in the area of the missing extremity. So it's felt wherever the arm or the leg has been amputated. Although the limb is gone, the nerve endings at the site of the amputation actually continue to send pain signals to the brain that make the brain think that the remaining part of the limb is still there. So even though the patient doesn't have that foot or those toes any longer, the patient still has the nerve track that once led to those toes. And so when that nerve track that has now been severed sends its pain signal to the brain doesn't know that that pain is no longer actually coming from the toes and instead coming from the site of the amputation. And so the brain perceives that as pain in the toes, and that's what the patient feels, even though the toes or the foot is no longer there. It is a very real pain, and it is important that we treat it properly, that the patient is medicated. However, I can tell you that it is difficult sometimes for us to get proper control of pain with phantom limb pain. For one, because narcotic analgesics, opioid analgesics, do not help with this particular type of pain well, because it is a neuropathic pain. Oftentimes we have better success with anticonvulsant therapy in treating this particular type of pain. So, but it is important to recognize that it is real and that it does need to be treated. As time goes on, with prolonged phantom limb pain, there are other therapies that can be employed if the phantom limb pain remains a consistent problem for the patient. Mirror therapy is something that has been used with documented success to help to minimize phantom limb pain, getting the patient to actually look into the mirror and see, so that the brain processes those images that that foot is actually, or whatever extremity is no longer there. One last thing that I want to mention with amputations is just talking about the emergency care of an amputation. In the event of a traumatic amputation, especially one where replantation is a possibility, some things to keep in mind with how would we handle the emergency care of that severed extremity, be it appendage, be it a finger or a hand or an arm. What we need to do, it's important to note that any amputated parts should be wrapped in preferably a sterile cloth that has been dampened with normal saline, sterile saline. Obviously, if you're not in a sterile environment when this occurs, it just needs to be dampened, a clean cloth, dampened with clean water. But again, the preferential treatment would be sterile saline and sterile gauze to actually wrap the appendage in that. Again, just damp, not saturated. Put it into a sealed plastic bag first. Once it's wrapped in the moist cloth, it's placed into a plastic bag. Then that plastic bag is placed on ice. So we do not want direct contact between an amputated part and ice or water, because this would actually cause further tissue damage and cell death, and it would leave it unable to be replanted. So again, it's just important to keep it moist, yet keep it off of the ice and water directly. So it goes into that plastic bag first. If a patient was to present in an emergency room setting with an amputated finger, that's what you would want to immediately do with that amputated finger until the decision was made as to whether or not it could be reattached. Another thing to note is that, generally speaking, tourniquets should actually not be applied to traumatic amputations unless it's absolutely necessary, only to control bleeding. Some other things is that, you would just want to cover an amputated part with a dressing. If the dressing becomes saturated with blood, you would want to continue to reinforce that dressing, not take it off and reapply new ones. And if there is continued or excessive bleeding, obviously we can apply pressure over the area and we can notify the physician.